All right, everybody be seated, please. Okay, here we have all of our jurors back. First question by the court. Ladies and gentlemen of the jury, anyone have any issues regarding the admonitions that need to be reported to the court? I see no indications of such. Very good. Appreciate it. Welcome back from lunch. At this stage, State of Ohio, ready to call its second witness?
State of Ohio calls Dr. Nguyen.
This is Dr. Nguyen, correct?
Raise your right hand. Do you swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
Good afternoon, Doctor.
Afternoon.
Before we begin, you probably know we have some folks from the media that are here. Do you have any objections to the potential of your likeness being used in some type of a video feed or anything else?
Yeah, I'd rather not.
I'm sorry?
I'd rather not.
You would rather they not. So, folks over there, any recording of it, not to include the face, okay? All right, and sir, I can already tell you appear to be a soft-spoken individual. I'm going to need you to really blast out that testimony. You see the lady all the way in the back in the plaid top. Try to make her hear you, okay?
Sure.
All right. Ms. Hiley, you may proceed when you're ready.
All right. Doctor, would you please state your name for the record, please?
Quan Nguyen.
Okay. And can you speak just a little louder? Because I think there's other sound in the courtroom, so
Sure.
we're not always catching that. So say your name again, please.
Quan Nguyen.
Thank you, and I think that's a good volume. Would you go ahead and spell your last name?
Nguyen.
And are you a doctor?
Yes.
Do you hold a medical license to be a doctor then?
Yes.
And how long have you been a doctor?
Graduated residency in 2013, so
So you've been a doctor since that completion of that residency.
correct.
And in 2013, is that when you obtained your medical license?
My full medical license, yes.
Okay. And your voice is dropping just a little bit, so make sure you keep it up.
Okay.
Okay. Full medical license, what state is that medical license in?
Ohio,
Where do you work?
at Fort Hamilton Emergency Department,
And how long have you worked for Fort Hamilton Hospital?
about 5.5 years.
And what is the location of Fort Hamilton Hospital?
The address,
The address, the city, that's fine.
630 Eaton Avenue in Hamilton, Ohio.
Okay. And what is your position at Fort Hamilton Hospital?
I'm an emergency room physician.
And can you explain briefly for those of us who may not fully understand that, what is an emergency room physician? What are your duties and what kind of things do you handle?
I see and treat emergency inpatients.
So in the emergency room, is there a limitation about what types of emergencies you address, or is there a broad spectrum?
Broad spectrum.
Okay. And if you could just kind of give us a brief from maybe what the lowest is that you consider all the way up to what the highest spectrum is of what you see in the emergency department of Fort Hamilton Hospital.
The highest would be a cardiac arrest, and the lowest would be a sneeze or a medication refill.
Okay. All right. So in your capacity as an emergency room doctor at Fort Hamilton Hospital, were you working in the early morning hours of March 8th of 2018?
I believe so.
Okay. You and I have met before to discuss your medical records that you prepared regarding the treatment of a patient named Hannah Weshy.
Yes.
Okay. In your treatment of Hannah Weshy, does the hospital prepare medical records that record your treatment and your assessments of Hannah Weshy?
Yes.
If I may approach the witness with State's Exhibit 4.
You may.
If they're just the Fort Hamilton records, that's fine.
State's Exhibit 5 is also attached, which is part of those. It's the
Scans.
yes. So it's actually State's Exhibit 4 and 5 for the record.
All right, thank you.
Doctor, if you want to go ahead and take a look at those and tell me if you recognize those.
So they say Kettering, but they're Fort Hamilton, is that right?
Yes, Fort Hamilton Hughes is part of the Kettering.
Right, okay.
Okay.
We're good.
That's the Kettering network. medical record.
Okay. And I think you just heard a comment. Is Fort Hamilton Hughes part of the Kettering Health Network?
Yes.
And are those the records prepared related to Hannah Weshy?
Yes.
And if you could go ahead and look at those and tell us on what date you came into contact with Hannah.
It's like March 8th, 2018.
All right. Are you able to tell us what time you came into contact with Hannah? And if you need to refresh your recollection with the records, just let us know that before you do that. Doctor, are you refreshing your recollection with those?
Yes.
All right.
I need to. Looks like on March 8th, 2018 at 07:44.
All right. Could you describe for the ladies and gentlemen of the jury what your observations were of Hannah Weshy as you came into contact with her on the early morning hours of March 8th?
Sure.
And doctor, are you reviewing the medical records to do that?
Yes.
All right.
It's like she was well developed, well nourished, in acute distress. She was toxic appearing and with multiple ecchymosis. And she had a Glasgow Coma scale of 6.
Okay. I want to go back and ask you a little bit about that. You say acute distress. What does that mean?
So usually it needs immediate intervention.
Okay. Toxic appearance. You described that. What do you mean by that for those of us who are not medical?
She looks sick.
And you said multiple ecchymosis. What does that mean, ecchymosis?
Bruising.
And you talked about a Glasgow Coma scale. Can you explain to us what a Glasgow Coma scale is?
It's how we determine their responsiveness during a trauma,
What is the purpose of the Glasgow Coma scale?
to determine what intervention is needed.
And explain for us very briefly, if you can, what are the different things considered for the Glasgow Coma scale, how you measure that, and how you said there was a Glasgow Coma scale of 6. So what that means and how you came to that.
I'm going to review the record.
Sure.
It has 3 parts. Number 1 is the eye response, and number 2 is verbal response, and then motor response.
Okay. And what is the lowest score you can get on that scale?
A 3.
And what do you have to do to get the score of 3? Or what does the patient appear to look like with a score of 3?
Completely unresponsive.
Okay. And you noted a Glasgow Coma scale of 6.
Okay.
If you could explain, you talked about the different things that you look at, the 3 different things. How are those scored? Where do the numbers come from?
Sure.
And what scores did Hannah get in the emergency room?
Sure. So she had no spontaneous eye opening, so that's a 1 on a scale of 4. So the highest you would get is a 4, which is a spontaneous eye opening. She had a 1 for verbal response, which is no verbal response, and she had a 4 to motor response, which is a withdrawal from pain.
So that's how we got to a 6 at that point in time.
Correct.
All right. Now, you talked about your overall view of her appearance. Did you then do a physical exam of her body?
Yes.
And could you describe anything that you noted in your physical exam of her body?
I have to review the record.
All right, thank you.
So it looks like,
While it's reading, if maybe the witness could be instructed to tell us what page it would be helpful for me to follow. He's reviewing the records.
sure,
Doctor, when you get to that point where you find that, if you could just
Sure.
tell us what page of the records that's on?
So on page 6, at the top, it says right side mandibular area with ecchymosis, superficial abrasion, contusion, and the chin appears with contusion, ecchymosis,
Okay.
and the
Contusion, what does that mean?
bruising.
And I think you said ecchymosis, that's also bruising?
Mhm.
So just two different words, or is there a difference between ecchymosis and contusion?
No, just the same.
Okay. And you also said abrasion. What are you talking about with abrasion? What is an abrasion?
There's a breakage of the skin.
Did you do an evaluation of the eyes of Hannah Weshy?
Yes.
And
Also-
go ahead.
Oh, sorry.
Go ahead
Also
and-
on page 6,
Also on page 6, thank you.
right pupil approximately 4 to 5 millimeter, non-reactive. Left pupil approximately 3 to 4 millimeter and sluggishly reactive. The conjunctiva is normal. Periorbital ecchymosis or bruising, left worse than the right, with no crepitus and bilaterally no deformities. Fundus exam showing blood bilaterally.
All right, and we had a lot of medical terms in there, so I just want to make sure that we understand what you're talking about.
Sure.
All right, and when you say right pupil, you're giving a measurement 4 to 5 millimeter, that's the measurement of the pupil?
Correct.
When you say sluggishly reactive, what are you talking about? What do you do to make that measurement or determination?
Reaction to light response.
And so could you explain, just in case there's some of those of us that maybe don't understand what that means or what the eye is supposed to do?
Sure. So in a dark area, the pupil dilates, and you shine a light in there, the pupil will constrict. And that's, so when we shine the light in, we kind of look at how it reacts.
Okay. And so in this instance, with Hannah, did her pupils react when the light was shined in her eye?
Looks, the right did not, the left very slowly.
Okay. And is that abnormal?
Object.
Coach.
This is Dr. Rand, Lindsay Partin. He's not an expert.
No, you can hurry up and-
This applies to the incident's care physical to allow treatment to make that concentration. Thank you so much.
Yeah, I did see that there were some cases right outside, I don't know if it right, yeah.
We didn't eat those last night.
Yeah, because it was late and they were probably, they were tired, yeah.
So, on the right, you say here? I already said public study for everyone.
It's for everyone, anybody can park in it.
You're good. So tonight, they'll close, so moving on.
It's open on its own. So if you came uptown for something, you could park there.
We should pay? Let's pay that.
I'm sorry?
Would you pay if you came at 9 o'clock?
No. If you want to do it during the, and I'm not exactly sure, I mean,
I'll do my best to object.
during the week, 7 to 6, something like that,
Observations.
that you have to pull but at night if you came up on the weekend. Yeah, they have a specification that, but I don't know. I don't know if they don't. So you came up for, you know,
No, who owns it?
That was during the day, like I paid, you know, I'm not there.
It's something on the radio.
I'm sorry.
Probably not over expensive.
This one we call.
But I checked it before that, and then my brother laughed, he told me, you know, there's people working with
Normalcy versus abnormality, I am going to sustain the objection and order that you disregard that and be straight. Ms. Hiley, you may proceed.
Doctor, did you record those findings regarding the pupils because they were significant?
Yes.
You also talked about a fundus exam. What is a fundus exam?
Where we looked at the back of the eye.
Okay. And you noted what with that fundus exam?
There was blood bilaterally
And how do you do a fundus exam?
with a ophthalmoscope and looking directly in the back of the eye.
Okay. And I know that, we're using a lot of medical terms. You said a ophthalmoscope, is that what you just said?
Yeah.
Okay. It's probably hard in non-medical terms, but as simply as you can, explain what that is.
It's a light instrument that we look through.
Okay, thank you. Did you do a further view of Hannah below her head?
Yes.
And what did you observe there?
I have to review the record.
All right. And if you could tell us what page you're on?
Sure. Do you only want the abnormalities or everything?
Things that you noted that would be of significance to you
Okay.
in your treatment.
On page 6, under the thorax and lungs, there are multiple contusions on the anterior chest area. The ribs were non-tender to palpation, no step-offs, and no deformities or crepitus.
All right. If I may approach the witness with State's Exhibits 41, 44, 46, and 50.
Good night.
It's the one that's right here. Yeah, I think that's it. Where's that? The other one's
You can go ahead and take a look at those.
I think you're going to rule this, but I just want to put it on the record while he's looking at this.
Okay. And are you able to recognize the individual in those photos?
Yes.
All right. And you've described a number of injuries. Do those photos accurately and truly depict the injuries as you observed them on Hannah Weshy the morning of March 8th of 2018?
Yes.
All right. And I know states exhibits 41 and 50 have previously been admitted. I would go ahead and publish those, as well as ask to admit states exhibits 44 and 46. And
Mr. Fagan, I'm going to note that you had the same objection to 44 and 46 as the previous exhibits earlier, correct?
Thank you, Judge.
I will rule those, Ms. Eiley. They will be admitted. You may publish whenever you wish.
all right, doctor, on the screen in front of you, you have States Exhibit 41. As you noted in your records and the observations, can you point out, and you can actually circle on that screen, what injuries you observed on Hannah the morning of March 8th?
That's there.
All right. And States Exhibit 44. Let me clear this. All right. States Exhibit 46.
I didn't know if it was done, I'm sorry.
And doctor, I know that we've gone through those, and just to be sure, what are you circling here so that we have a good record of that?
The bruising and the skin abrasion.
Okay, bruising, you're circling both eyes, and an abrasion on the left cheek, is that accurate?
Yeah.
Okay. I'm gonna go back to 44, just so we can talk about, you circled on 44, what part did you circle on 44?
The chin.
And on 41, which parts did you circle?
The chest and the eyes and the cheek and the chin.
Okay. Finally, States Exhibit 50. All right, and what are you circling there?
The bruising on the chest.
Based on your observations of Hannah Wesche, what treatment did you deliver?
Have to review my record.
All right.
So the patient presented to the emergency department with an unresponsiveness, which with evaluation upon arrival with a Glasgow Coma scale of 6, on page 11. She was not protecting her airway, unresponsive, and at this time suspecting head injury. A decision was...
I'll object to the reading. It's a question, not reading from the document. That's my objection.
I'll address it and I'll restart this.
All right,
Okay.
well,
Doctor, if you can, our request is you can use those use the records to refresh your recollection,
Sure.
but then testify as to them after you've refreshed your recollection.
Sure.
So if you could go ahead and look at that. And your testimony does not need to be verbatim, just your understanding of it after refreshing your recollection.
Okay. So she arrived in the emergency department unresponsive. She wasn't protecting her airway, so made the decision to intubate and put her on the ventilator.
And when you say intubate, what do you do to intubate?
I put a breathing tube down her throat and help her breathe.
Did you administer any other type of treatment or medication?
We gave her medication to facilitate the intubation.
Okay. During intubation, could you have caused any of the injuries that we've previously seen that you circled?
Absolutely not.
Would that have caused any injuries on Hannah during the intubation externally?
No.
Did Hannah ever require CPR while at Fort Hamilton Hospital?
No.
Did you contact any outside hospital for assistance in treatment with Hannah?
Yes.
And who did you contact?
Cincinnati Children's Emergency Department.
And based on that contact, what was your plan of care?
We were to intubate her and set up for a air care transport to their emergency department.
And then did you do that?
Yes.
While at Fort Hamilton Hospital, did you order any additional screening?
Yes.
What did you order?
A CT of her head, her neck, and her face.
And did you remain with Hannah as those were completed?
Yes.
And were those completed then that morning on March 8th?
Yes.
What time did air care arrive?
I have to look at the record.
All right. Doctor, if I may
Yeah.
assist you in locating that, page 15 of those records.
Here's was documented at March 8, 2018 at 08:34 a.m.
All right, so a little more than 45 minutes that Hannah would have been at the hospital?
Yes.
Did you note anything about Hannah's condition? Did it remain the same? Did it change throughout that 45 minutes at the hospital?
She remained the same.
Jack, I think that goes to the expert fact witness.
Up to this point, I can't rule out that this would be based on observations only, so I'll overrule the objection at this point.
I'll listen to it and follow up.
All right, thank you.
Did her condition deteriorate?
No.
Were there any changes in her vital signs?
Not that I'm able to recall.
Doctor, in completion of your treatment, do you document within those records a summary of what your treatment and care was?
Yes.
Would page 11 have that summary on it?
Yes.
If you could take a moment to look at that to see if there's anything that you noted that would help refresh your recollection.
It appears the patient's heart rate was slowly dropping.
All right. So at 8:34, when air care arrived, was care then passed on to a different hospital?
Yes.
And who was that passed on to?
Cincinnati Children's.
So was Hannah and the records that were prepared by Fort Hamilton Hospital then forwarded on to Cincinnati Children's?
Yes.
Doctor, in your care of Hannah Wesche in that 45 minutes that she was there, is there anything that occurred at that hospital that would account for any external injuries on Hannah?
No.
Could you describe the type of care that you gave her?
She received very good care, and no one ever did anything to inflict any external injuries to her.
Would she have been jostled or held down or anything throughout the time she was at Fort Hamilton Hospital?
Absolutely not.
And why not? How can you say that?
Because when suspecting a head injury, we take all the precaution that comes with ATLS and PAL's recommendation to be very careful in manipulating or moving the patient and try to move as little as possible.
All right. If I may have just a moment.
You may take your time.
Your Honor, I do move to admit the records that he's been reviewing. They are certified copies.
Ms. Pagan, wish to be heard?
No, we don't wish to be heard on the revision of records.
State Exhibit 4 and 5.
I don't have an issue.
No objection. Stacy's Exhibit 4 and 5 then will be admitted. No further directive, Ms. Hyland?
I'm sorry. No further direct.
All right, thank you. Mr. Pagan, you may cross whenever you're ready.
Thank you, Judge. I'm going to need the exhibit so far. Let's see what you got here. Thanks. So I'll give it back to you. Where's one? Yeah.
They're also part of Exhibit 4.
I might have trouble finding them. Thank you. Don't look nice. I'm going to give you back the report. First of all, good afternoon.
Good afternoon.
My name's Chris Pagan. I'm the defense attorney. I don't have a whole lot of questions, but I have some.
Okay.
Thank you for being here. Is this your first time testifying?
Yes, sir.
Okay. I hope it's pleasant. You testified about a thing called the Glasgow Coma scale, correct?
Yes, sir.
You did that as part of your treatment.
As part of my examination.
Thank you. As part of your examination prior to treatment?
Yes, sir.
Okay. And I think you found a notation about the GCS, the Glasgow Coma scale, in the records, correct?
Mm-hmm.
Yes?
Yes.
Say yes and no. I believe that would be depicted on page 6 and page 7 of the hospital records.
Yes, sir.
Do you have those in front of you?
Yes.
I'm going to show you what has been not part of your testimony, but somebody else's, State Exhibit 1.
Okay.
Okay? I'm going to put it up on a screen for you to see. It's been previously admitted. Undo?
Clear the marking.
doing it? Bottom clear. Where it says clear? Help.
No.
Thank you. Never have to do it again. Okay. All right. So I'm going to point, just a simple question. GCS, you understand that to be an abbreviation for?
The Glasgow Coma Scale?
Okay. And I'll proffer to you that State Exhibit 1, which is what's up here, is what the transporting EMTs, their report.
Okay.
Okay. I want you to look at the language right here. Under 11. I know it's small. Do you need it enlarged, Denny? Can you read it?
Yeah.
Okay, I want you to read it, and when you're done, just let me know, and I'm going to ask you a couple questions about that.
Initial,
Just read it to yourself,
Oh.
and then I'm going to ask you some
Okay.
questions. First time, no worries. You're done?
yes, sir.
Okay. What you just read depicted there, would that be the entirety of the Glasgow Coma Scale?
Yes.
Okay. Let's. I'm gonna grab your medical records, and I'm gonna put them up on the screen for you to see. Is it fair to say that the Glasgow Coma Scale is broken up into 3 parts?
Yes.
So eye response, verbal response, and motor response, correct?
Yes.
Okay. And right there where I'm pointing at, that's the beginning of the Glasgow Coma Scale, correct?
Yes.
And that's the 4 things you look for eye response,
Yes.
correct? And that's page 6. I'm going to move to page 7. Beginning at the top, that's the verbal response, correct?
Yes.
And you're looking for those 5 cues to score the verbal response, correct?
Yes.
Okay. And then below is the motor response, correct?
Yes.
Okay. And you're looking for those 6 clues for motor response, correct?
Yes.
All right. So what I've just gone through in your records is the entirety of all the clues, and I guess there would be 4, 5, 11, 15 clues, correct?
Correct.
All right. And that's the full test.
Correct.
All right. And you indicated that you did that test as part of your examination.
Yes.
Okay. And going back to State Exhibit 1, when I asked you inartfully whether or not this represented the full test, these 2 notations here, what I meant to say, they don't include all of the clues, correct?
No, looks like those are the pertinent positive that they were documenting.
And if there was prior testimony before this jury that represented the full scale, that wouldn't be actually correct, would it?
Well, those were the positive that they
Right.
found.
But not the ones that were not found. It didn't include all of the clues.
That were positive.
It included the ones that were positive in States Exhibit 1, but did not include the ones that were negative.
Correct.
Okay. What's depicted in your hospital records, and again, we'll show it, does depict the full test, right?
Correct.
And I won't have to show it then. You ordered some scans done,
Yes, sir.
all right, but they were interpreted by a radiologist.
Yes, sir.
Okay. you were provided with, I think, were there 4 pictures? Yes. I'm going to ask you some questions about those, okay?
Okay.
Those photographs, you didn't take any photographs during your examination and treatment.
No, sir.
All right. You were too busy doing medical stuff and not documenting what pictures, right?
Yes, sir.
Okay. And you don't know who took those photographs?
I don't.
You don't know when those photographs were taken?
I don't.
Can you even say, I mean, you could probably guess, but you don't know where, with firsthand information, those photographs were taken?
No.
You don't know whether or not they were pre or post-operative?
I don't.
Okay. You don't know what happened to Hannah before the photographs were taken?
I don't know anything happened prior to her arrival.
Or after? After she left
She left.
your hospital about an hour after she arrived?
Correct.
Is that correct?
Yes, sir.
Okay. But you did observe some bruising?
Yes, sir.
Okay. And you did take a history as part of your evaluation with respect to the bruises in some respect?
Yes, sir.
Okay. And do you, I know it's been a long time, and I bet you see tons of patients on one day, let alone a year plus later. But do you recollect whether or not you took that history yourself or whether or not a nurse took that history?
We all do it at the same time.
Okay. I appreciate that that's your testimony about what you generally do, but I'm asking specifically, do you have a recollection as to whether or not you took the medical history in this particular case?
I always take the medical history.
All right. And I appreciate that answer, but I'd ask you to listen carefully to what my question is and just answer that, which is, do you have a specific memory of taking the medical history in this particular case?
I remember taking the history, yes.
Okay, so you do.
I always take the history when the patient comes in.
Were you with a nurse or not?
Yes.
Okay. If you have a specific memory, who did you take the history from?
The paramedics
Okay.
and I think, may I see my note?
Do I have it? Yeah. And of course you can. But before I give it to you, is it fair to say that you don't have an independent recollection without reviewing your notes about who you took the history from? Fair?
Yes.
Okay. And I want to give them to you the way I got them, which is bound up.
Sure.
Because I tend to mess things up. I hope you can move.
Sure.
Did you find it?
Yes, sir.
Okay. And I found the history on page 44. What page are you on?
Page 4.
Page 4. I saw that. Is it your experience that the same history can be repeated a couple of times in medical records?
Possible.
Okay. We'll look at page 4 and then go over to 44 and then see whether or not it's the same history. I think that it is.
I think it's the same note.
And was it your note or a note of a nurse?
It's my note.
Okay. And at the top of the note is HPI. What does that stand for?
History of present illness.
Okay. And there's 2 paragraphs after that, correct?
Yes.
All right. Well, I'm going to show it to the jury if you don't mind, and it'll come up right there. I'm going to zoom back so it can be read. Okay, can you all see it okay? All right. So just, it's probably obvious, but just not to overlook obvious things. History is what?
What had happened?
Okay, and who do you take it from?
Anybody that knows what happened?
Okay, and it's part of your examination?
It's part of the history taking.
Yeah, and it allows you to get a sense of what happened to the patient and how to proceed and how to care for them.
Correct.
Okay. And it's part of,
My history and physical.
well, but it's a part of every time you treat a patient, especially emergently, correct?
Correct.
Okay. So first, let's start right here. The history indicates that the father was at the bedside, correct?
Correct.
Do you remember that? Or no?
I do not recall, but
Okay.
it's
You have
documented.
no reason to dispute your note.
Okay. You're
Is that
right.
right?
Correct.
Okay. The woman right there, the blonde woman right there at that table, she wasn't there.
I do not recall.
Do you know her?
No.
First time you've ever seen her? Okay.
I don't recall.
You don't recall if she was there or not?
No.
Okay. Your note doesn't indicate that the babysitter was present, right? It was just the father.
Correct.
Okay. And there's a comma, and then it explains, apparently the child collapsed this morning after the went into the babysitter's house, who lives next door to them. As the father getting ready to drop her off, according to him, the child collapsed and became unresponsive. So that he carried the child back and put him on the couch and called 911. Otherwise, he stated that the child was completely in a normal state of health without any problem until this morning. He stated that he was told by the patient's babysitter that he stepped on a toy yesterday and fell forward from standing, striking her head, however, without any loss of consciousness and acting completely normal. After the fall, no nausea, no vomiting, no complaint of pain, no complaining of headaches or blurred vision or double vision or anything at all. And then he picked her up the next evening, correct? That's what he told you, and after hearing that, you found it important enough in the history to put into
Correct.
the note. And this, you believe, was coming from the father who was at the bedside.
Correct.
And you don't have any independent recollection from any other source but the father.
Correct.
And going on, the father gave you further information in the history, which is the child ate dinner and completely herself, then was put to bed and woke up this morning, was completely at a normal state of health without any issues until he went and dropped her off at the babysitter, which was next door, and at that time the child collapsed. Correct?
Correct.
All right, so there was, do you recollect whether or not you were taking a history to assess the origin of the bruising?
And yes, and why she's in the emergent state that she was.
And also her lack of responsiveness, being unconscious, all of that. That's why you're taking this information.
Correct.
And he relayed to you this fall that happened the day before. Correct?
Yes.
Okay. And that she slipped on a toy, right?
Correct.
Okay. And that she struck her head, right?
Correct.
Okay. But otherwise, she was asymptomatic after that.
Correct.
Okay. But then he amended his statement later in the history and indicated to you And again, you identified the father as the historian, correct?
Correct.
All right, and we'll go through it so that you have a chance to think about it. The father then stated she had been intermittently complaining of headache for the past 3 weeks that was mild in nature and still with normal behavior and acting normal and no deficits that they could see. Correct?
Correct.
So in his initial history, he indicated there had been no problem after the fall with respect to headaches.
Correct.
Okay. And then later he said, well, wait a minute, she has been experiencing headaches, unexplained headaches for 3 weeks.
Correct.
Okay. And you found that to be important enough to put in your note?
Correct.
All right, 2 more questions about the history. All right, after the father told you in the history that he had picked Hannah up yesterday evening, you indicate in his history that he says, and the child and ate dinner. Did you understand him to say that Hannah ate dinner with him on the night before, which is March the 7th, 2018?
I don't know who Hannah ate dinner with.
Okay. Would you agree that that statement indicates that the father said that he ate dinner with Hannah? I mean, this is your writing.
I understood that she ate dinner.
Okay. And that the child ate dinner was herself.
Correct.
All right. And then here, again, this is information you got from the father, correct?
Correct.
About Hannah, right?
Right.
And the statement is, he then subsequently called 911 for further help and evaluation. Did he indicate to you that he, in fact, called 911?
I believe so.
Okay. And it turned out that the defendant did, either you heard it wrong or he said it to you wrong.
I do not recall.
Okay. You indicated that you spoke with the paramedics as part of your history.
Yes.
Did they relate to you any concerning or disruptive behavior on behalf of the father at the scene?
I don't recall.
Okay. Just a couple more questions. And I'm sorry, I think you said this and I didn't catch it, and that's why I want to affirm it. Were you able to identify in the records the exact time that the paramedic unit arrived at Fort Hamilton Hospital?
ED arrival at 0744.
$7:44?
Yes, sir.
And were you able to identify from the records the exact time that she left in the air care from your care and from Fort Hamilton Police Hospital?
Patient transferred to air care transport cart. handoff care at this time. Patient en route to Cincinnati Children's. Timestamp at 0834.
So Hannah was at your hospital from 7:44 to 8:54.
Correct.
Did you observe the handoff to the team that flew her down?
Yes.
One second, and then I think I'm done.
Take your time.
When you took the history from the paramedics, did they indicate to you that they had hurried Hannah away from the scene because they felt that she was unsafe at the scene?
I do not recall.
Do you recollect whether or not they described the mechanism of how they handled her as they took her to the ambulance from the scene?
I don't recall, assuming as fast as possible.
You indicated that based on your exam and part of your treatment, you placed her in a C-collar.
Yes.
That was to stabilize her head.
Yes, sir.
Okay. And that's because of the head injuries that you observed?
Well, because of the concern for possible head injury.
Gotcha. Would it, based on what you said, would it have been concerning to you if anyone at the scene had scooped her up while she was in a distress condition?
Define scoop.
Grabbed her without a C-collar, without stabilizing her head.
I mean, I can't speak for EMS protocol.
Okay. What a, all right. That's all the questions I have.
Thank you, Mr. Becker.
Thank you, Judge.
Ms. Holly, you may redirect when you're ready.
Doctor, if the EMTs described scooping up Hannah, having their hand behind her neck and holding her close to them to get her out to the EMS, would that concern you?
Possible.
Okay. And how so?
If she had a neck injury or C-spine injury,
But if it was a head injury, would that cause any issue? As opposed to a neck injury?
I don't know.
Okay. You have the records up there in front of you, correct?
Yes.
Okay. Let me approach the witness. Doctor, I'm going to put up State's Exhibit 4, which you've been talking to somewhat at length with counsel. And I have some questions for you. At the top it says ED provider notes 3/8/2018 at 9:23 a.m.
Tell me what page you're on.
I'm sorry, page 4.
Thank you.
Do you see that? Can you see
Yes.
that on the screen? What is that 9:23 a.m.?
I think that's possibly when my note was completed or entered.
Okay. So you would agree with, I'm sorry, let me rephrase that. Was Hannah at the hospital at that point in time at 9:23 a.m.? You've testified previously that she left at 8:34.
I don't think she was there.
All right. So you believe that's when it was entered into the computer. And I guess, let me ask this a different way. Do you enter this information into the computer as the information comes to you? So in the emergency room, as somebody is saying something to you, are you recording this history in the computer?
No.
Are you doing anything to record that history, like an audio recording, anything along those lines?
No.
Do you have a transcriptionist, or are you taking any notes related to that at that point in time?
No.
What are you doing at that point in time?
Listening to the history and taking care of a critically sick patient,
So as this history is coming in, where was Hannah?
laying on the ER stretcher.
And as the history was coming in, Hannah was there? You said laying on the stretcher. So was she in the room with you when this history was coming in? That's what I wanted to
Yes.
say. All right. And being in the room with you, where was your focus at that point in time?
On the patient,
And so when do you finally put this stuff in writing, this history?
sometimes from then in 923.
Okay. There's also a notation here, and that, just so you can help us to understand, it says under that ED provider notes, it has the 923. It also says filed at 12/15 and date of service 923. Are you able to explain what those different things mean?
Are you still on page 4, Kim?
Yes, I am at the top.
I believe the 1215 is when the note was filed.
Okay. And 923, what do you think that was the time of? What do you believe that was the time of?
Possible when the note was first entered.
Okay. I don't have anything else.
Thank you, Ms. Mr. Pickett, any recross based on that?
I think just one question. Which means subparts. I shouldn't. I know better than that. I appreciate that your primary purpose is medical care, correct? That, right?
Correct.
Your primary focus at that moment was Hannah, correct?
Correct.
Her care,
Correct.
her stabilization,
Correct.
her your diagnosis,
Correct.
treatment plan.
Correct.
That said, do you have any reason to believe that the history you took is inaccurate or false? Sitting here today.
No.
Okay, thank you.
All right, doctor. Thank you very much. We appreciate your testimony. Is the witness subject to recall?
No, Your Honor, thank you.
All right, doctor, we just ask that you, first of all, be careful as you're getting down. And also, please do not discuss your testimony with any other potential witnesses, all right? Thanks, sir.
Thank you.
Ms. Hiley, who would the state call next?
Dr. Marguerite Cray?
Great.
Correct.
Stand here and raise your right hand, please. Do you swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God? Yes. Okay. Have a seat and please watch your step. Thank you.
Doctor, good afternoon.
Hi, hello.
Ma'am, you probably noticed we have media folks here. Do you object to potentially your likeness being broadcast by a media?
No, that's okay.
All right, very good. Ms. Hiley, you may proceed to direct whenever you're ready.
All right. Good afternoon, doctor.
Hello.
I'm going to ask that you keep your voice up. Sometimes it's hard to hear in this courtroom, so just make sure you're projecting as you're talking. Would you state your name for the record, please?
It's Marguerite Care, spelled Care, Care. It's my last name.
All right, and if you could lift your voice up just a little louder.
It's Marguerite Care.
Thank you. And would you said C-A-R-E was the
Yes.
last name? Okay. And you're a doctor?
Yes.
A medical doctor?
Yes.
When did you graduate from medical school?
I graduated from medical school in, college in 1993.
Okay. So college being your undergrad, is that what you're saying?
Correct.
and medical school in 1993.
Yes,
Do you hold a medical license?
yes.
Where do you hold a medical license?
I hold a Kentucky license, Ohio license.
So in addition to medical school, what is required to obtain your medical license?
So as far as my training after medical school, I did a residency in radiology, which is a 4-year, at the time was a 4-year program. And then I did that at University of Cincinnati. And then I did a year of pediatric fellowship in pediatric radiology, which was at Cincinnati Children's. And then I did a year of pediatric neuroradiology also at Cincinnati Children's. And that was after I got my medical license.
Okay. So to get your medical license, in addition to the undergraduate, whatever residency you have, is there any kind of testing or
We have to-
maintenance for that?
You have to pass your board exam and finish your medical school degree.
Okay, so there is an exam at the end?
Correct.
All
Yeah.
right. And you said finish your degree, then is there anything to maintain that licensure that you must do?
So to be certified, like by the American Board of Radiology, I have like a lifetime certificate for general radiology, but we do what we call like a maintenance of certification. So we have to do continuing medical education throughout the years. We really don't have to take a board exam again, but we do online questions. It sort of has evolved over the years.
Okay.
So I have that in pediatric radiology.
And you talked about a fellowship.
Yes.
Can you explain what a fellowship is?
So like after medical school, we do training in whatever field we want to go into. So I did radiology, and radiology is basically you CT, MR, MRI, radiographs. You can do interventional radiology, mammography, ultrasound. And so we do specialty training in those areas. And then I did a fellowship, which is after residency, you do more specialized training. So some people will do musculoskeletal, cardiac imaging, fetal imaging. I did pediatric radiology. And then I did the additional year in pediatric neuroradiology. So I did that at Children's, where I do, so basically I do brain, spine, kind of head and neck. That's sort of my area.
All right, so you're saying pediatric radiology, you're talking about radiology of children.
Correct.
Is that
Yes.
children of all ages?
Yes. I mean, we actually see a fair amount of adults as well that have pediatric diseases that go on to complex congenital heart disease patients that may now be 50 years old or can be seen at Children's as well. So, but yes. So we see all pediatric aged patients as well as patients with pediatric diseases.
And you talked about CT, MRI, and specifically, let's talk about those. I think you named a few other things, but I think specific to this case, what is a CT?
So CT is, it's sort of a fancy X-ray. It's CAT scan, computed tomography. And so it allows us to see inside a child's brain and look at the actual brain structure, where if I took an X-ray of you, you would actually just see more of the skull, like you would see a skeleton. The CT allows us to see inside. We can look at the inside structures of the brain, the soft tissues of the neck, the chest, abdomen, wherever we do the CT imaging.
Okay. And in comparison to an MRI, what is an MRI?
So an MRI is even a fancier tool that we use for imaging. It's magnetic resonance imaging. It allows us to see, again, inside, and we do that sort of on different, kind of depending on what the symptoms are. A child that comes to the emergency room that we need a quick study, that we're trying to look for, let's say, trauma, kids vomiting, we're worried about a mass. We may do a CT scan because it's a quick study. It can be done within, a couple of minutes versus an MRI. If anyone's had an MRI, it can take 45 minutes to an hour to do. It's just a more specialized study looking at the soft tissues.
Okay. Do you have any board certifications?
Yes, so I'm boarded by the American Board of Radiology, and then I have certification in pediatric radiology.
And do you have to do anything to maintain those certifications?
Yes, that's what I was saying. We have to do
Okay.
additional CME, continuing medical education, as well as we have to fulfill other requirements to do those. That sort of runs on a 10-year time period. I did it for one time where I had to take a certification board, exam. It has since changed and it's evolved some. So now we do online questions. I get questions sent to me on a weekly basis that we have to pass a certain number of those online questions per year.
Okay, and thank you for that clarification. I appreciate that. What is your current position?
I'm a staff neuroradiologist, Cincinnati Children's.
And how long have you been at Cincinnati Children's Hospital?
I started my fellowship in 1997. I've been there ever since. I was faculty, I think, in like 2000, April of 2000, somewhere around there, so about 20 years.
Do you have any teaching responsibilities?
Yes, Children's is a teaching institution, so we have, within our program, we see the residents and fellows. We have fellows actually assigned to our program, so again, these are post-medical school, post-residency people that are doctors that are learning about pediatric radiology. We have University of Cincinnati residents that rotate with us, and then we see all the subspecialties kind of rotate through our department, as well as the medical students from UC's medical school.
In addition to those teaching responsibilities, have you had the occasion to create scholarly articles that are peer-reviewed and published?
Yes. Yes, so I'm pretty much I prefer to do clinical medicine beyond the service, but I certainly have done, I do lectures, I've done some lectures at national meetings, I do some research, child abuse, abusive head injury is one of the areas. I've also done some work on tuberous sclerosis. I kind of get, some of that work, yes.
Okay. And I'm sorry, that last word I kind of lost. You said you did tuberous sclerosis?
It's tuberous sclerosis.
Okay, thank you. What is that?
So it's a disorder that can have skin findings, brain findings. It's I've worked with some of the neurologists that I know. They were sort of the main people. So they can have certain kinds of brain tumors. So I helped them assess the brain tumors.
Okay. So a short, fancy way of saying brain tumors, is that what we're talking about? With the...
In that specific disorder, yes.
Okay, thank you. During the course of your duties at Cincinnati Children's Hospital, do you evaluate patients?
To be honest, the radiologists, we don't really see patients. Like, if you come into the radiology department to get a chest x-ray or a CT scan, mostly who you're going to deal with are technologists, who are the imagers. And then we basically, everything is sort of sent to a computerized PACS system or picture system where we kind of sit in a separate room and review the imaging. So there are times when I do see patients, but in general, I don't typically see patients. I used to do more interventional procedures where I would do lumbar punctures or cerebral angiograms, so I would see those patients. Occasionally, I will talk to a patient if a child comes in and maybe we discover that the child has a brain tumor. I may go talk to the family and meet the child that way. But in general, radiologists often don't see patients.
Okay. You're looking at scans of the patient, not the actual patient. Is
Correct.
That what you're saying?
Yes.
Okay. And so when you're asked to review scans, can you tell the ladies and gentlemen of the jury what types of scans or for what reasons are you looking at these scans?
So I do, like I said, I do neuroradiology, so a couple of us work per day. We look at the CT and MRI studies that come across, and we see lots of different things. We see kids with seizures, infections, kids that might have been in car accidents. We see kids that come in with vomiting or headache that may turn out to have brain tumors. We see a lot of neuro-oncology patients, brain tumor patients at Cincinnati Children's. So kids that have seizure disorders, epilepsy, so lots of different things.
Doctor, have you previously testified in a courtroom?
Yes.
Have you previously been declared an expert in the field of pediatric radiology?
Yes.
In what courts?
I'm not sure I'm going to be able to. I've been here in Butler County, I've been in Hamilton County, and then in Kentucky. And to be honest, I'm not sure I can even tell you what county that was in Kentucky.
All right. Doctor, at some point, did you provide the state of Ohio with a curriculum vitae, which is basically a summary of your education, experience, and training that you received?
Yes.
Publications that you've done?
Yes.
If I may approach the witness with State's Exhibit 11. Are you able to recognize that exhibit?
It's a copy of my CV, yes.
True and accurate copy of that?
Yes.
As you're looking at that, I know that there's a number of pages, but do you see any glaring additions or corrections that need to be made in that?
No.
Move to admit State's Exhibit 11.
Any objection from the defense?
Does not.
All right, Exhibit 11 will be admitted.
Your Honor, at this time, the state requests that Dr. Cray be qualified as an expert in the area of pediatric radiology.
Mr. Pager, do you wish to order the witness any further on qualifications?
Non-qualifications.
All right, the court will find her so qualified to testify as an expert in pediatric radiology. You may proceed.
Doctor, pursuant to your duties as a pediatric radiologist with Cincinnati Children's Hospital, did you evaluate any radiology images of Hannah Weshy, date of birth 1/11/2015?
Yes.
And were records developed as a result of Hannah Weshy's treatment at Cincinnati Children's, which began on March 8th of 2018?
Yes.
I'd like to hand you what's been marked as State's Exhibit 8.
Yes. What number is that? Thank you.
Doctor, are you able to recognize State's Exhibit 8?
Yes.
And what is that?
These are copies of the imaging that was done, that was put in our PACS system. The initial study was actually from Fort Hamilton, but these are copies of the discs.
And the initial studies done at Fort Hamilton, did they become part of Cincinnati
Yes.
Children's records?
Mhm.
Move to admit State's Exhibit 8.
Mr. Pager?
Children's Hospital records?
Yes, that's what they
Objection.
Exhibit 8 will be admitted.
Doctor, when you evaluated the CT images, or did you evaluate CT images of Hannah Weshy in this case?
Yes.
And when you did that, did you develop medical records within there describing your findings,
Yes.
right? And following your description of those findings within the medical records, did you also prepare a supplemental report related to your findings?
What do you mean, so supplemental report in addition to my radiology report?
A supplemental report or a report that you provided to the state of Ohio summarizing your
Oh,
findings?
yes, yes.
Sorry. This is just pulled from. Pulled from the Children's Hospital records. No, you just keep it up there when I'm not there. It beats having to go through 4,500 records. So, thank you.
Four, 5, 1, 3. Through 4, 5, 2, 0. All right, now I may approach the witness.
You may.
Thank you.
Dr. State's Exhibit 9, are those your results that would be within Cincinnati Children's Hospital medical records?
me just look. So CT, yes. Yes,
All right. And State's Exhibit 10, that is that report that you provided?
Yes.
to the state. Doctor, if you could describe the reasoning for your evaluation, and actually, let me rephrase that. When did you first evaluate slides or CT images related to Hanawashi?
so the morning, I was working the morning that she was brought to Children's. We actually electronically got the imaging from Fort Hamilton, and so I actually evaluated it prior to her going to the operating room and discussed the findings with Dr. Stevenson, the neurosurgeon.
So you're saying you evaluated the images from Fort Hamilton Hospital?
Correct. We often will get, if a child is coming in or a patient is coming in from an outside institution, whether it be a brain tumor, a trauma patient, whatever, if there's pertinent imaging, it will be put into our system, and that study will have been read at the institution that it was performed at, let's say Kentucky, and then we will actually generate our own report so that our physicians can treat kind of based on what we think in case we happen to disagree with those findings. So that's not uncommon that I would interpret an outside study.
And
Smiling, I apologize. Is everybody able to hear the witness and the jury? All right, I was just double checking. My apologies.
lost my train of thought on that for a second. That's all right. So you said you do a follow-up evaluation, and on this morning, or you do a follow-up analysis, something separate from what was done at the prior hospital.
Right.
And
Right.
I think you alluded to it, but I just kind of want to understand, in this specific instance, why did you review those records? What was the purpose of you reviewing those records and doing your own follow-up on March 8th?
So the child was being sent to Cincinnati Children's, so we were reviewing them, trying to figure out what was going on in the scan so that the neurosurgeon knew. I mean, the neurosurgeon had been notified that the child was coming so that we could talk to the neurosurgeon about the findings on the CT scan. And then again, that's put into our system, and then we generate our own report.
And so, prior to coming to court today, did you prepare a PowerPoint presentation to discuss the findings that you saw
Yes.
in Hanawashi?
Yes.
If I may approach the witness with State's Exhibits 12 through 18.
Give me a minute.
Thank you.
Doctor, are you able to recognize those?
So these are copies of the slides that I prepared.
And within those slides, are there images from the CT of Hanawashi?
Yes.
Are those true and accurate images as you reviewed them?
Yes.
At this time, the state of Ohio moves to admit and publish State's Exhibits 12 through 18.
Mr. Pagan?
That's just what I saw, Kelly?
Yes.
Yeah, that's fine, no objection.
All right, State's Exhibits 12 through 18 will be admitted.
And it's going to take me just a second to pull that up. Doctor, starting with State's Exhibit 12. Are you able to see that on the screen there?
Yes.
Just a cover page identifying Hanawashi and her date of birth.
Yes.
So State's Exhibit 13, if you could talk us through your findings, what we're seeing here, and the significance of those.
Do I have a way of pointing on the image
You
or
can
no?
actually touch it and it will mark it.
Okay.
So you can go ahead and touch to whatever you're talking about.
Okay, so these are actually three, so a CT scan basically is, like I was describing, as an X-ray, not an X-ray, it's radiation basically, but we're able to look inside and look at the child's brain, and then we can display them different ways. So these are actually displayed almost like if you have a loaf of bread. It's a slice. We can kind of make slices all the way up the head. We can do them in this direction. We can do them in that direction. We can actually make 3D reconstructions of the skull or the soft tissues. And so we can kind of generate different imaging depending on how we look. This is sort of our standard way to look at the brain. We call these axial images. So again, they're sort of going this way up through the brain. And so these are actually 3 separate locations in the child's brain. And this is from the head CT that was performed at Fort Hamilton Hospital and then put into our system that morning. It was done, I guess, looks around 8 o'clock in the morning at Fort Hamilton. And so on the initial study right here, on the initial image that I have, the one on this side, these are actually the markers that were put in by Fort Hamilton. It's showing the child's brain here.
Are you marking on the screen?
Is it not doing anything? Push.
Don't worry about being gentle with it. Just
If you use your fingernail more.
until you see.
Oh, okay.
There you go.
Here, and I'll
Okay.
clear that off. Go ahead.
So this is the child's brain in here. Is it working?
Yes, it is.
Oh, now I've got scribble all over.
Do you want me to clear it out?
Sure.
I'll let you start again.
Okay, so on that image, what that's showing is the line going down the middle is showing where the ventricles or the fluid spaces that we all have in the brain should normally be located. And you can see that these are the fluid spaces that are the dark spaces off to the side. Well, let's just go back to starting with the basics. So this is the bone. The white area out here is the child's bone. The inside here is the child's brain. And then we'll get to the bleed here in a minute, which is this portion over here. So what we're trying to look for is we look for sort of symmetry between the two sides. When we look at imaging, this is the right side of the body and the left side of the body. We always sort of look at our imaging like we're looking at the patient. And so it sometimes gets a little confusing as to which side we're on. So the child's brain is being pushed over to the left side, and there's this area outside of the brain that's in the subdural space, and that's moderately sized collection that's got high attenuation or bright white. High attenuation is something that we see with hemorrhage that's recently occurred. It's got some areas of dark in it. So to me, this is a subdural hemorrhage that's occurred that's causing mass effect on the brain and kind of pushing the brain over. This is just an image. The second image is just higher up. And then this is an image even higher up, sort of more at the top of the child's brain. Again, showing areas of kind of white or subdural hemorrhage outside the child's brain. And then this is actually the brain itself here. Do you want me to keep going, Joe?
Is there anything else that we should talk about in this slide?
So the significance here is when we see bleeding outside the brain, a couple of the big things, when I see this on a study, I need to quickly get a hold of someone. To me, this baby's brain is being pushed. Someone needs to either do something to relieve that pressure, take off that bleeding, or do something. Because as the brain continues to get pushed, it can cause significant problems. The child can have significant hypoxic ischemic injury related to that shift. Bleeding outside of the brain, we see that in different settings. Certainly trauma is going to be the most common thing. When we see bleeding in the subdural location, we think trauma. It's not the only cause of subdural hemorrhage in a child, but it's the most common. The other thing is, and we will go on to look at another child that's similar age, the brain attenuation, or sort of the colors, I call them colors, that's sort of shades of gray. The child's brain is kind of subtly indistinct to me, suggesting that there's already kind of some issues going on in the child's brain at this time.
Okay. I want to go back and try to understand some of the things that we're talking about. Number one, we're talking about a subdural hemorrhage. what does a subdural hemorrhage mean?
Okay, so normally the brain is going to be positioned in the middle of the head, and then we have different spaces where bleeding can occur in the child's head. So we can have bleeding that can actually be in the central fluid spaces, which are these locations here. We can move out a little bit and have what we call subarachnoid hemorrhage, which is this space which we all normally have a subarachnoid space, and it communicates with the cerebrospinal fluid or fluid that we normally have. If anyone's ever had a lumbar puncture, that's the fluid they take out. And then we move out a little bit further, and we've got this subdural space, which is sort of, some people talk about it's a potential space where bleeding can occur, which is where this location of the blood is. And we can tell the location by what it appears, the shape of it. It's sort of that crescentic shape. And then if you move out further, we have what we'll call epidural hemorrhage, which classically epidural hemorrhage is going to be sort of confined by the periosteum of the bone. It's more kind of lens shape or biconvex, and it's another type of hemorrhage. So we're actually looking at hemorrhage outside of the child's brain, but within the skull, not actually in the child's substance of the brain.
Okay, and so there were a number of different, I think, their locations, but I'm hoping you can kind of clarify. Maybe a brain or a head anatomy discussion of what is the subdural space that you're talking about.
So they're just, they're kind of confined by the different membranes that overlie the patient's brain or anyone's brain.
And would that be on the outside or the inside of the skull?
It's on the inside of the skull, so contained within the bone, but outside of the brain.
All right, and when we're talking about layers of, it's not just skin, skull, brain, is there other things in between?
Well, the meninges, the dura, yes. So,
Okay.
I mean, there's vessels, yes. I mean,
All right, and would you mind kind of going through outer to inner, what those different layers are? As you're starting from the outside of somebody's head, going all the way into the brain, what are those different layers?
well, so on the imaging, the things that we look for is we look at the scalp. When I first pull up a CT scan, how I sort of approach it is I kind of quick glance at the brain. That's the main concern. Is there something big and bad I need to see on the brain? Do I need to let someone know what's going on? And then we sort of evaluate the rest of the structures. What's the attenuation or the color of the brain? Is the white matter, the gray matter, the normal color? Is there bleeding? Are the fluid spaces normal? Some people talk about like water on the brain. You have normal fluid spaces in your brain, and sometimes we'll see that those will get too big. Sometimes we'll see that they'll get too small. We'll look at the spaces outside of the brain. Then we want to look at the skull. Are there any fractures? Are there any bone lesions? And then we get to the scalp, where maybe the child's got a soft tissue lesion or soft tissue swelling in the scalp. And so we cover all of those. If I took images down lower, you'd actually see the orbits or eyeballs, and so we look at those as well.
Okay.
So we're sort of evaluating the entire head and all of the structures.
All right. And so you talked about subdural hemorrhage and then also the movement of the brain or the shifting of it within the head.
Right.
And states exhibit 14. What
So
are those showing and why
So
are they significant?
these are just reconstructed images. So like I said, we can take a CT scan. When you get a CT scan, we can often we'll send those axial images. Those are sort of the main images that we look at. At Children's, we actually routinely will send these images, which are coronal images, and then these are called sagittal images. So this is like you're actually looking at the child's brain, so right side of the body, left side of the body. And this is actually like you're looking sort of at the sideways. This is the face up here, this is the back of the head back here. And so that just helps us sort of see things, different kind of planes. And so these are, again, just reconstructed images from the initial head CT. Again, you can see it just shows us the bleeding up and sort of over that right cerebral hemisphere. You can see bleeding kind of along the midline, and then this is the sagittal image, which again just sort of shows it over that hemisphere. A couple of the arrows here, this is down as the brain at what I would call the craniocervical junction, so where the head and the cervical spine sort of connect. And this is just showing subtle areas of bleeding down at that craniocervical junction. The significance for me when I see that is The blood can track down, so it may just be some of that subdural blood that has tracked down. But what I worry about is when I have a child who's got trauma, especially like if I saw this child, if you told me this kid was in a motor vehicle accident, I would worry that this kid had injury to that craniocervical junction. So injury to the cervical spine, where it sort of connects into the head. And so that's why I have the arrows on that. So when we see subdural hemorrhage, I mean, like I said, the big thing for me that morning was Dr. Stevenson called down. I talked to him about the findings. We said, this kid, obviously he knew at that time already because the child had already been evaluated. This kid needed to emergently go to the operating room to have this hematoma evacuated. And if this were another kid that had come in any other time, like I said, the technologist, if this kid were, a motor vehicle collision or something else, and I saw this finding, I would emergently get on the phone and call someone and say, you guys need to get this kid to the operating room now. I mean, that's sort of our role. I certainly don't call on every scan. If the kid has a normal head CT, I'm not going to call the physician right away, but, we're here to identify significant findings and communicate those results.
And Dr. Stevenson, who is Dr. Stevenson?
He's the neurosurgeon that was involved with the care. Took Hannah to the operating room that morning.
And I believe you said you directly spoke to him regarding your findings and your observations.
Yeah, I spoke with him a couple times on the phone.
And I know there's a lot here to talk about, but at that point in time, what were your biggest concerns and what were the things that needed alleviated as best as possible at that point in time?
I mean, the main thing to me and to him was which side is it on? Which side does he need to go? And, are the images, what space is it in? That sort of helps them decide. And how much brain, mass effect does it have? And is the brain already abnormal? Those are some of the things that kind of help him. Sometimes they will remove the bone, and we'll see how they do that, where they'll evacuate out that blood and remove part of that bone. Very rarely, if there's a lot of blood on both sides, they'll do it on both sides. So, I mean, that's some of the main things.
In this instance, did it appear that the blood was localized to a side?
It was much more on the right side, yes. Mm-hmm.
States Exhibit 15.
Do you want to erase all my, yeah. So these were when we look at imaging, we can, the technologists will send us what we call soft tissue windows and kind of bone windows or bone algorithm. And so we look at those axial, coronal, and sagittal images in brain windows, and then we also look at bone. And the bone, we can't see the brain as well. So you can see you don't see the brain as well. I've got them kind of light. And then I can manipulate to make them brighter or darker, depending on what I want to look at. So like if I've got a child that's got a potential stroke, I make the windows look very different because it kind of helps me see the stroke better. Bleeding the same way, kind of edema in the brain. So we can kind of manipulate that on our computer systems. Basically what I'm showing you here are the arrows are pointing to areas of swelling in the scalp, so soft tissue swelling outside of the bone. So like I said, this is left side, this is right side, so there's left frontal swelling, and then this is right kind of posterior parietal, or kind of the back of the head on the right side, swelling. Why I look at that in a child, especially if a child I'm concerned about has trauma, that kind of guides me to look for other things. Does a child have a fracture? So if a kid comes in and the history is, got hit in the head by a lacrosse ball, I usually will go through and I'll look at the whole scan, but then I'll go back and I'll be like, okay, where did this kid get hit? And I'll kind of make the windows look a little bit different. Oh, it was here, so is there a fracture here? Because if the kid got hit here, we're not going to find a fracture back there. So it kind of guides me to where I need to look and kind of clue in a little bit more.
Following reading these initial CT scans from Fort Hamilton and speaking to the neurosurgeon, Dr. Stevenson, did you do a follow-up study?
So Dr. Stevenson took the child to the operating room and evacuated the hematoma, and then the child came back down, which is routine. They come back down and get another study within a certain time period. usually to see now what's going on after they've evacuated the blood. So yes, there is a follow-up.
All right, and States Exhibit 16, I
Oh.
think, is
So this
still
is
the same one.
Yeah, so this is basically, this is, on this side, this is Hannah's image here, and then this is just a normal 3-year-old child that I pulled from our system for a fall. We see lots of kids that come in with falls. This is what the normal 3-year-old brain should look like. The ventricles or the fluid spaces should be here in the center. Again, if you kind of draw a line down the middle, you can see how Hannah's ventricles are pushed off to the side. The left lateral ventricle is actually a little bit smaller. And when I talk about the attenuation or the color of the brain, you can see how it's almost like you've got darker areas centrally. Some of these areas are whiter, and that's sort of the normal appearance of the brain on this side versus on Hannah's. You can see that you don't see those colors or the different blacks, shades of gray quite as nicely.
Doctor, are you able to say what is causing that shift?
Right, so when we see kids with large subdural hemorrhage, certainly the subdural hemorrhage itself can result in the shift. Subdural hemorrhage is typically caused by injury to venous structures, called like bridging veins. You have arteries which supply blood to the brain, and then the veins drain the brain as anywhere else in the body. And so subdural hemorrhage usually results from bleeding or injury to the bridging veins. And so not only do you have the subdural hemorrhage, but if you have injury to those veins, the brain itself is not going to be draining normally as well. And so you can get edema within the brain.
And edema is? What does that mean?
Swelling.
Okay.
Just like if you injure yourself in your hand and it starts to swell.
States Exhibit 17. Explain to us what these are showing.
Okay, so these are 3 different images of Hannah. So this was the initial study that we've been looking at, the same pretty much image. This is the initial post-operative study that was done after Dr. Stevenson had done the evacuation, and this was an imaging study that actually one of my colleagues, Dr. Cook, had read 3/9. This was done the next day, and that's not unusual. Again, we usually will do a couple-day, follow-up just to see what's going on in the child's brain, sometimes depending on how well clinically they're doing. So again, this is the bleeding here. So now you can see on the initial post-op one here, the skull, which is the white area here, has been resected in this large area here. And now you can see that the brain is what we kind of call herniates, or it kind of protrudes into that. So Dr. Stevenson removed the bone here, was able to drain that hematoma. But because of the swelling in the brain actually herniates out into that defect. If we draw that line down the middle on the initial post-operative study, the shift, what we call midline shift, has relatively resolved, although you can see again that brain is sort of herniating out. But then again, by the following day, you can see, if we kind of draw down that middle, how the brain is shifted over again. You can also see how the attenuation of the brain, you've got more areas of black. Here you've got areas of black as well. And so the child has really ended up having diffuse injury to that right side. And on the left side, I don't think we show all the images, I might show them, also had injury to the left side as a result of that initial midline shift. So when we get that initial midline shift, you can cause injury or to some of the arteries supplying portions of the brain. And so not unusual, or not infrequently, we'll see areas of the brain on the opposite side that are injured because of the initial shift.
So in this, because it looks like, based on your description of the later CT on March 8th, it looks like in that, and you mentioned that midline shift had corrected, the point of March 9th, that portion of her skull is still removed. correct?
Right, so they take, basically what they're doing is they're doing a decompression. They know this brain is very swollen. They need to not only evacuate that subdural, but they need to leave room for that brain to kind of, if he put the bone flap back on or didn't remove that bone, the brain would continue to swell, and basically it would cause, the child would not, it would injure the brain stem and the child would not be able to survive. And so they leave that bone off, and it gives the brain the ability to kind of swell out, and, hopefully to decrease that shift and kind of secondary injury to other parts of the brain. So they can leave it off. They leave it off sometimes for, we see the follow-up studies on these kids sometimes months after the decompression, and they still have not necessarily replaced the bone flap.
Is there a reason, or do you know a reason for the midline shift and the follow-up then on 3-9, why that would be back?
So on the 3-9 study, the child's brain just, basically the child has diffuse injury, edema, basically what we see in these kids is we see kind of injury involving that entire hemisphere. It's not just an arterial distribution, it's not just a venous distribution. To be honest, I don't think we exactly understand why, but it's a very common pattern that we see in kids that have large subdural hemorrhage. And we'll see injury to that entire hemisphere. And so the brain is just continuing to swell, and it is swelling enough now that it not only is herniating out through that bone defect, but again, it's pushing inside, on the inside.
And when it pushes inside, is that causing further damage?
Correct, yeah.
And I know you circled on the middle one some dark spots.
Right, so
And I
those
think
are,
you talked about attenuation, so what does that mean?
so those are, again, just areas of injury. Typically, CT, we kind of, we can look at those and we can say those look like areas of hypoxic ischemic injury, hypoperfusion injury, the blood's not getting there appropriately, the brain is not getting oxygenated. If we did an MRI on this study, we have some sequences in MRI that we can do that you would do like if you had a stroke, if you had an adult patient or even a pediatric patient with a stroke. And that's typically what we'll see is we'll see what we call like cytotoxic edema, or again, it's not an arterial stroke, but it's sort of injury in that sort of manner to the brain. And so that's what we're seeing here. We're seeing the loss of that normal attenuation. So we're seeing edema or swelling to the brain.
All right, States Exhibit 18.
So, these are just, again, the initial, this is the follow-up head CT from the 9th, and then this is, again, just what a normal 3-year-old child's brain should look like.
Doctor, I know in this initial CT, you talked about, and I believe you described where you saw the bleed. By that follow-up CT, and let's go back to States Exhibit 17. By that follow-up CT, had that bleed resolved?
So what Dr. Stevenson and so what the neurosurgeons will typically do, and like I said, we see the follow-ups on these, so they will remove that bone, and then they can open up that dura, and they can evacuate or take out, sort of get rid of this portion of the brain. So what he described in his operative note, and what we can sometimes see on imaging if we are able to get certain kinds of imaging, is that the veins, there were 2 veins that were still bleeding at the time of surgery. And so he was able to coagulate those veins that were over that right cerebral hemisphere. But typically what we'll see is on the follow-up, it's not infrequent that we'll sort of see some bleeding or kind of oozing reaccumulate in certain areas. So he is working over here, and it's not infrequent that we can kind of see on the follow-up that there'll be oozing in that midline area. It's not really causing a lot of mass effect at that point.
And
Not
by
really
mass effect, you mean?
pushing on the brain.
Okay. In the initial CT on 3-8, where you see it along the right hemisphere, is that causing mass effect?
Right, so that's causing that shift, which is how, when we look at hemorrhage, when we look at collections, we're trying to figure out, okay, what's this doing to the baby's brain? Because that's the big point. You know, the brain is the important structure. If this were a subdural hemorrhage that wasn't pushing the brain, the child might not have needed to go to surgery. But because there's significant midline shift, there's already, suspected injury already. Here, it's important that they go and try and get rid of that to decrease that pushing or mass effect on the child's brain.
And I know, doctor, you talked about the CT being kind of quick and not as thorough and not as good of images as an MRI. So why wasn't an MRI done on Hannah?
CT is actually a very excellent tool. I really like CT. MR is much more fancy. It's much longer. It's magnetic resonance imaging. We can't put a child, or we don't put everybody in. CT is what we use for trauma. Very good for looking at the bones, very good for looking at the brain, very good for looking at the hemorrhages. So CT is sort of the initial study. Basically helps guide our initial kind of medical and surgical management of these patients. If this child had survived, we may have done an MR on her at some point. It's not infrequent that we would do an MR several days into the hospitalization to kind of show the injury to the child's brain a little bit more extensively. We may then look at the spine as well. So magnetic, because it is a magnet, not everybody can go in. Again, we don't put critical patients typically in the MR scanner because a CT, we sort of describe a CT as a donut. And so the child is sort of in this donut where an MR is more of a tube, not as safe to put a child in there that's devastating. An MR is a longer study. We have a couple rapid MR sequences that we can do, but a CT, the imaging is pretty much done like that. And so this kid needs to emergently get to the operating room. I don't have half an hour to do an MRI on this child.
And doctor, she was in the hospital for 10 days following this. Why was there a follow-up on 3/9 with a CT instead of doing an MR at that point?
Again, usually we will do an MRI when the child is stable. I really wasn't involved in sort of her follow-up. I think at this point, by the time 3/9, her brain was pretty significant. So
When you say pretty significant, what do you say?
Significant brain abnormalities. I'm not sure what the medical decisions were as to why an MR wasn't done, other than I don't think anybody felt at that point she had survivable injuries. If she hadn't had survivable injuries, maybe they would have done an MR. I don't know the answer to that.
Okay.
So
That's not your call about whether or not
Correct.
those scans are done. Doctor, based upon your education, training, and experience, and to a reasonable degree of medical certainty, do you have an opinion as to whether the bleeding that you observed on Hannah's brain in the CT from 3/8 that was taken at approximately 8:09, whether or not that was an acute bleed?
yes, I think this is an acute bleed.
And what, since we said acute, what does acute mean?
So when we look at bleeding on CT, we do look at the attenuation or the kind of gray-white scale on CT, which we all sort of learn in our training what things should look like when they're acute. When I look at this, what helps me the most is what is it doing to the baby's brain. Like I said, we can see subdural hemorrhage that is bright white and it's doing nothing to the child's brain. And although I might think it looks recent, acute to me is recent, like it's very recently occurred. But if it's not doing anything to the brain, the surgeon doesn't need to do anything. So to me, a child can have fluid in their subdural space and it not push on the brain at all. And so that, I kind of look at that and I'm like, well, the brain's sort of used to having it there to a certain extent. And so, could it have been recent? Yes, but the brain's nothing's happening to the brain. To me, when we see mass effect on the brain, that suggests an acute injury.
And you mean recent injury is what you're saying?
Recent, yeah. So we have to sort of look at not only the attenuation of what it looks like, but also, more importantly, what is it doing to the child's brain?
And doctor, to a reasonable degree of medical certainty, do you have an opinion as to what caused Hannah's injury?
So when we see subdural hemorrhage, we see subdural hemorrhage from trauma is going to be certainly the most common cause, and not only in the pediatric population, but it's going to be more significant trauma. We see kids fall all the time, and typically we don't see subdural hemorrhage from trauma that occurs on an everyday basis. When I see a young child come in with subdural hemorrhage, the first big thing I think about is abusive head trauma, abusive head injury. Certainly, if you told me this kid was hit by a car, I would be like, yep, this pedestrian hit by motor vehicle. Subdural hemorrhage is typically going to be seen in significant accidental injuries, motor vehicle collisions, kids hit by cars, and then abusive head injury. Not typically seen in small kind of garden variety falls. Even kids who fall out of two-story windows sort of have a different pattern of injury. So Dr. Stevenson and I, when we discussed it, he had not seen the child, and we were kind of like, do you know anything more about this kid? Certainly that was what I conveyed to him is certainly I'd be worried about abusive head injury. Are there other injuries to this child that we know of? And at the time, he did not.
Project.
Approach.
Where we ended in that, one of the things, did you speak to other doctors that would have treated and cared for Hannah in coming to your opinion in this case?
So I initially saw the imaging. Dr. Stevenson and I spoke on the phone, and then the child went to the operating room. So I also do, we haven't really talked about it, but I also am a member of the child abuse team at Cincinnati Children's, and so I've also reviewed it at that. As far as my opinion, I pretty much knew.
All right, Ms. Filey, based on the conversations we had, if you'd like to re-ask the question, we'll see where the answer leads us at that point.
All right, doctor, I'm going to ask, and in my phrasing this question, I don't want you to express any opinions by any other doctors. However, I do want to know your opinion. And I think we've talked about the causes of this injury. Did you receive any medical history in your evaluation of Hannah Wesche and her slides from any source that would be consistent with the injuries that you were seeing?
I received no information of a significant accidental injury. By the time I signed off the report, I knew that she had significant bruising.
Okay. So you knew she had significant external bruising, is that what you're talking about?
Correct.
That's by the time you signed off on the report?
Correct.
Had you already developed an opinion prior to seeing that external bruising?
Yes.
And you said there was no significant accidental history. What do you mean by significant? What are you talking about?
Like I said, so if I see a scan like this, most of the time the child's going to present initially to our trauma bay, and we'll know before the child even gets to our trauma bay that there's a 3-year-old coming in that was involved in a motor vehicle collision or a motor vehicle accident. If a 3-year-old or a 16-month-old comes in with no history, no trauma history, comes to our trauma bay, and I see a scan like this, abusive head injury is going to be one of my main thoughts. We don't see subdural hemorrhage from a lot of things in the acute setting. Motor vehicle collisions, kids hit by cars, abusive head trauma. If this were a post-operative patient, a kid with a shunt, I can see subdural collections not infrequently in those kids. But to see it just out of the blue, it's very uncommon from, in children just with routine trauma.
And you say abusive head trauma. What is abusive head trauma?
So someone has caused injuries to the child, and when we talk about head trauma, it can be anywhere from the scalp, the skull, to the actual brain. some people used to call shaken baby. Shaking is one thought as to how these injuries occur, but unfortunately, lots of injuries can occur different ways. We have kids who, will find, potentially blood on a wall. You may find kids who are, people say that they threw them across the room, they slammed them down. So any sort of inflicted trauma on a child. Radiology is actually a very important part because we have these young kids coming in who we don't know what's going on with them. So like I said, if I have a 16-month-old who comes into the trauma bay, no one knows what's going on. We don't see any external signs on this child. We get imaging and see this. Obviously, abusive head injury is kind of top on our list. We then will go on to suggest other imaging studies where we will look for other injuries called a skeletal survey, which Hannah did have, and she did not have additional fractures, but we will do what is called a skeletal survey, where it's a study that we take bone images looking for occult fractures or fractures that we can't find clinically. And so that is routinely done on young children. Usually we do that up to about 2 years of age.
You talked about different mechanisms that you see cause abusive head trauma. Would a single fall event explain the findings that you have here?
I mean, we see kids fall all the time. I mean, I think we all have anyone who has their own children, we see kids fall all the time out in the community that don't even come to the hospital. I work 4 days a week clinical. I see kids every day that have falls off counters, falls out of car seats, and this is not the type of injury that we see. Short distance falls, like I said, we may see external swelling on the child's head, we may see a fracture or an actual break in the skull. Usually if we see kind of a short distance fall and we see a fracture, we may see a little bit of bleeding deep to that, but usually it doesn't cause any problems to the brain. It's not pushing the brain. The child may cry, but neurologically they're not terribly abnormal. Sometimes those kids might get admitted, sometimes they just go home. So this is not what I would expect from a short distance fall, no.
What about a series of falls over several days?
No.
Based upon your education, training, and experience, and to a reasonable degree of medical certainty, are you able to say whether or not Hannah would have been acting normal, would have been walking or talking and appearing normal to those who knew her after receiving the injury?
Yeah, no, this is a significant injury. Like I said, we see these injuries in, kids who have been involved in similar injuries, kids hit by cars, motor vehicle collisions, abusive head injury. These kids they present acutely. Acutely meaning I would not have expected her to be acting normally. I would not have expected her to be walking. Usually these kids are not able to breathe on their own. They're, have to be intubated. They're usually unconscious. The child emergently needs this removed, or this is a potentially fatal injury, and in her case it was. Even with surgery, it was a fatal injury. So this is a significant injury.
Probably have just a moment.
You may.
Doctor, since there was some discussion back and forth when we were talking about your determination of abusive head trauma, is that finding of abusive head trauma, is that to a reasonable degree of medical certainty?
Yes.
Nothing more.
All right, thank you. Ladies and gentlemen, I know you have been patient. We've been going a little over 2 hours now. We're going to take a little break here to give you a chance to refresh yourself before we jump into the cross-examination. I'm now noting it is 3:08. I'll give you about 15 minutes, so if you can assemble back near that rotunda area, about 3:23-ish, 3:25-ish on your watch. Ms. Wilson will be looking for you. Please leave your notepads, but keep your lanyards on. Please remember your admonitions about not discussing the case amongst yourselves or with anyone else, not researching and so forth. And we will go back on the record at that time. Thank you very much.